Every day, nearly 40% of Americans over 65 swallow 5 or more prescription pills, each meant to heal, but sometimes colliding in dangerous ways. Polypharmacy was supposed to extend life, yet it now triggers confusion, devastating falls, and repeat hospital visits. How did medicine's best intentions become the hidden dangers of too many medications? To answer that, we need to go back to the moment everything changed. By the early 1990s, a new philosophy was taking hold in American medicine. Disease-specific guidelines urged doctors to treat each chronic condition, hypertension, diabetes, high cholesterol, with its own set of medications, often adding drugs when targets were not met. Medical journals and professional societies published updated protocols that called for aggressive control, spelling out thresholds, and recommending combination therapy as standard for many older adults. Meanwhile, pharmaceutical companies ramped up their marketing efforts, flooding television and print with ads that promised better living through chemistry. Direct-to-consumer advertising soared after 1997 as the FDA relaxed rules and drug makers spent billions to reach patients and physicians alike. For many clinicians, the message was clear. More prescriptions meant better care, especially when insurance reimbursement and performance metrics began rewarding adherence to these guidelines. By the end of the decade, the average number of medications per older adult was climbing rapidly, setting the stage for the era of polypharmacy that would soon dominate geriatric care. Polypharmacy describes the regular use of 5 or more prescription medications at the same time. For older adults in the United States, this has quietly become the norm. Nearly 40% of people aged 65 and older now take at least 5 different prescription drugs every day. This is not a rare or fringe phenomenon. It is the lived reality for millions. The reasons are often complex. Multiple chronic conditions, specialist appointments, and overlapping prescriptions that accumulate over time. But the sheer scale is staggering. Each new medication brings its own risks, and as the number of pills climbs, so does the chance of unintended consequences. Polypharmacy is no longer just a clinical term. It's a daily challenge for older Americans, their families, and the health system itself. The numbers tell only part of the story. Behind every statistic is a person managing an ever-growing list, often without a clear sense of which medications are truly necessary. Mrs. Evelyn, an 82-year-old retired teacher, started with a single prescription for urinary urgency. Her doctor prescribed oxybutynin, hoping to ease her symptoms. Within weeks, her daughter noticed Evelyn seemed confused and unusually drowsy, struggling to follow conversations or remember familiar routines. Concerned, the family reached out to her physician, who interpreted the confusion as agitation, possibly early dementia. To manage these new behaviors, an antipsychotic was added to her regimen. The changes were swift and unsettling. Evelyn became more sedated, her balance worsened, and one morning she fell in the kitchen, fracturing her wrist. The hospital team reviewed her medication list and traced the chain of events. One drug side effect misread as a new illness, prompting another prescription and another, until a preventable fall brought her to the emergency room. Her daughter later reflected, "It felt like every new pill created a new problem. We just wanted her back." This is how a prescribing cascade unfolds, not in theory, but in the lived experience of families like Evelyn's. The dangers of polypharmacy reveal themselves in hard numbers and clinical realities. Studies published in JAMA Internal Medicine show that for older adults taking 5 or more medications, the risk of falling, experiencing cognitive impairment, or developing delirium rises by more than 50%. These are not rare complications. They are routine outcomes in hospitals and care facilities across the country. When the medication count climbs to 10 or more, the danger escalates sharply. Adults in this group face a 60% greater risk of suffering a major adverse drug event compared to those on fewer drugs. These events range from sudden confusion and dangerous drops in blood pressure to life-threatening heart rhythm changes and severe bleeding. Clinicians on the front line see the pattern every day. A geriatrician might recount how a patient admitted for a broken hip was found to be on 12 different prescriptions, several of which were interacting in unpredictable ways. Pharmacists warn that every added pill increases the complexity of care, making it easier for mistakes to slip through and for side effects to go unnoticed until they cause real harm. The financial impact is staggering. Adverse drug events driven by polypharmacy cost the U.S. healthcare system billions of dollars each year, draining resources from families and hospitals alike. For many older adults, the true price is paid in lost independence and preventable suffering. These numbers make one thing clear: unchecked polypharmacy is not just a statistical problem. It is a public health crisis demanding urgent attention. For older adults and the clinicians who care for them, the American Geriatric Society's Beers criteria stands as a critical safety net. First published in 1991 and updated regularly, this list identifies medications that carry higher risks of side effects, drug interactions, or complications in seniors. It acts as a red flag system, a practical checklist that helps doctors, pharmacists, and patients pause before adding or continuing a drug that could do more harm than good. Pharmacists rely on the Beers criteria every day, especially when reviewing long medication lists. During a medication review, a pharmacist scans for drugs on the list, flagging those with strong evidence of risk in older adults. For example, certain sleeping pills, strong antihistamines, and many anticholinergic medications are called out because they can cause confusion, falls, or dangerous drops in blood pressure. The goal is not to ban these medications outright, but to ensure their risks are weighed carefully against their benefits, and to encourage conversations about safer alternatives. The Beers criteria also empowers patients and families. The American Geriatric Society offers a patient-friendly guide and a printable checklist. By bringing this list to appointments, patients and caregivers can ask targeted questions. Is any medication I'm taking on the Beers list? Or could this drug be causing side effects? These questions open the door to meaningful dialogue, making it easier for clinicians to explain their choices or consider deprescribing when appropriate. For pharmacists, the Beers criteria is more than a reference. It's a daily tool for protecting patients. For families, it's a source of confidence, offering clear language to advocate for safer care. When used together, this list helps turn a complex medication regimen into a manageable, transparent plan, reducing risk and supporting healthier aging. Geriatricians across the country are urging a new approach: deep prescribing, the careful and supervised reduction of medications that may no longer be necessary or safe. The American Geriatric Society recommends that no medication should be continued indefinitely without a regular, comprehensive review. For many older adults, the idea of stopping a familiar pill brings real anxiety. There's often a fear that symptoms will return or that their health will suddenly decline. Experts emphasize that deep prescribing is not about cutting medications abruptly or without a plan. Instead, it's a stepwise process, with close monitoring and frequent check-ins between the patient, caregiver, and physician. This collaborative approach helps rebuild trust and addresses the psychological barriers that can make change feel risky, even when it is likely to improve quality of life. Mr. Robert, a 76-year-old retired engineer, once juggled 11 different prescriptions each day. At his annual checkup, he brought a complete list of every pill and supplement, handing it to his primary care doctor and pharmacist. He started the conversation with 2 simple sentences. "I'd like to review my full medication list with the goal of reducing my pill burden. Can we check whether any of these are on the Beers list or might be causing side effects?" Together, they created a step-by-step plan, prioritizing which drugs to taper and setting a schedule for regular follow-ups. Over 6 months, Mr. Roberts' medication count dropped to 6. He noticed fewer dizzy spells, clearer thinking, and more steady days. His experience shows how a single organized list and a direct conversation can open the door to safer, more manageable care. Genetic testing is opening new doors in medication safety. Pharmacogenomics, the science of how genes affect drug response, is moving from research labs to everyday care. In the coming years, doctors may use a simple cheek swab to help choose the safest medications for each individual, reducing the risk of dangerous interactions. Early studies suggest this approach could prevent a significant share of adverse drug events, especially for older adults managing complex regimens. For those seeking practical guidance and the latest research, Wisdom Years offers evidence-based resources for safer, more personalized care. Today, nearly 40% of older adults in the United States take 5 or more prescription medications, a rate that has more than doubled since the 1990s. Decades of disease-specific guidelines and pharmaceutical marketing led to widespread polypharmacy, often with dangerous consequences. Evidence from JAMA Internal Medicine shows that older adults on multiple medications face over a 50% higher risk of falls, cognitive impairment, and delirium. Yet the full impact of prescribing cascades and the effectiveness of emerging solutions like pharmacogenomic testing are still not fully understood. While tools like the AGS-Beers criteria now help identify high-risk drugs, and deprescribing is supported by geriatric experts, the challenge of balancing treatment and safety remains. What is clear is that regular medication reviews and informed patient advocacy can prevent harm. The legacy of the polypharmacy era is still unfolding, but every documented case points to one fact: vigilance is the best safeguard against the hidden dangers of too many medications.